Oh, sorry about that. I'd like to report that Councillor Green's presented her apologies for the meeting. I'll therefore be taking the chair for this meeting. I welcome everyone if you didn't hear the previous introduction there. I'd now like to ask Democratic Service Officers to set out the housekeeping arrangements for the meeting.
Many thanks. Please note that this meeting of the board is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. Please could everyone present follow these ground rules. Only speak when invited by the chairman. Please use the microphones on your desk when speaking, and please turn off your microphone when you're not talking. If accessing the meeting via Teams, please turn on your video function when invited to speak. If you are accessing via Teams and would like to speak on an item, please do so by utilising the raise your hand feature in the bar at the top of the Teams window. Just to confirm, only those members of the board present in the committee suite will be able to vote. However, as you will appreciate, we do have members of the board who are joining remotely, and obviously it's absolutely fine for them to participate in the debate but not to vote on any specific issue. For those in the room, please note that if the fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the ground floor of the multi-storey car park. Finally, please ensure background noise is kept to a minimum and mobile phones and other devices are switched to silent for the duration of the meeting. Thank you.
Thank you. So the first agenda item is the apologies. So again, I'd ask Democratic Service Officer to report on the apologies received for this meeting.
Many thanks, Chairman. If I can report apologies received from Councillor Nicola Green, Graham Farrant, who's the Chief Executive of BCP Council, Elaine Redding, Corporate Director, BCP Council, Scott Chilton, Chief Constable, and Sally Sandcroft from the CCG. And in context of substitute members, I can report that Brian Ralph is substituting for Elaine Redding. Welcome to the meeting, Mr. Ralph. Mark Harris is substituting for Sally Sandcroft. Welcome to the meeting, Mr. Harris. And Councillor Jane Kelly is substituting for Councillor Nicola Green. Welcome to the meeting. I'm not aware of any other apologies or any other substitutes, unless somebody wants to provide an additional update. Chairman, if you're happy, I'll move on to agenda item 3, which is declarations of interest, and ask members to make any declarations of disclosable pecuniary interest or local interest in respect of the issues before the board today. Agenda item 4, public issues. I can report there are no public issues for this meeting, and that's probably appropriate for me to stop at that point, Chairman, and I'll hand you back in relation to agenda item 5.
Okay, thank you. So we're down to item 5 then, the confirmation of the minutes. I just asked members whether they agree to confirm the minutes of the board held on the 17th of June 2021. Yep, I'm getting the nods from around the room, so we'll take those as agreed. Have members got any comments on the action sheet that accompanies those? Okay, we'll also take that as approved as well then. So to move into the business of today's meeting, so item 6 is anchor institutions, and I'm going to call upon Paul Eagledon. He's going to provide a brief update on the recent presentation held on this issue. I think Paul's joining us via the live stream.
Thank you, Chair. Yes, can you hear me okay over the remote link?
We can't hear you, Paul.
Can you hear me now?
If you can just bear with us, we'll try and resolve that issue with regards to the microphone.
Oh, somebody can hear me in the chat.
Yeah, we can hear you via Teams, Paul, but I don't think they
Right.
can hear you remotely in the room.
Via chat, is it sufficient for me to continue, or do we need to fix the microphone?
She just said they were going to try and fix it, and bear with.
You want to try speaking now, Paul?
Can you hear me now?
No, sorry, we still can't hear you. I think we'll move on to item 7, and we'll see if we can come back to Paul, see if we can sort that out. So item 7 is the eliminating food insecurity and the access to food partnership, and we had quite a detailed report on this at one of our previous meetings. So this is a follow-up to that, and we've got Kate Ryan with us, the BCP Corporate Director, and is Alistair with us as well?
Yes, I'm here on Teams, Chair, but again, I'm not sure you can hear me.
On Teams? We can't hear. Okay, we'll move on to that. So I'll hand over to Kate because she's in the room, perhaps, and can bring Alistair in.
Hi, thank you. You've got a full report around the work done with the Access to Food Partnership. I was going to hand over to Alistair to sort of summarise the key points which are in the PowerPoint, but I don't know if we'll be able to hear him. Can we just try to see if we can do that? Otherwise, I'll take.
Okay, so we can't hear Alistair either coming through, and Alistair was going to present this. So I'm going to suggest we just have a 5 to 10 minute adjournment at this point, and we'll see if we can get the sound working. Otherwise, we're not going to progress very much. So. Okay, welcome back, everyone. Hopefully we've resolved the slight technical issue there. So I'm going to revert back to the original order of the agenda and go back to item 6, the anchor institutions. So hopefully, Paul Eagleton, we can hear you now for an update. Okay, so I can't actually hear Paul, which is odd because we could hear him just now. Could I ask someone else? Can I ask somebody else on the Teams call to speak to see if we can hear anyone?
Hello?
Hello, hello.
Hello.
Hello,
I think Paul is on mute.
Oh,
we can't see your face, Paul, and we can't hear you. Which I'm assuming is at your end because we can hear everyone else. Okay, so we still can't hear Paul, so I'm going to suggest we revert to Plan B again, and we move on to item 7. Then the eliminating food insecurity, and we've got Kate in the room and Alistair online, so I'll hand over to Kate again.
Thank you. We've got a short PowerPoint, which only 2 slides, which just summarises what's before the board in terms of the full report, explaining what the Access to Food Partnership is, what it's delivered, and more importantly, I guess, in our allocated time, looking at prompting a discussion and a commitment going forwards from the board. So if I hand over to Alistair, who's been chairing the partnership, to provide you a quick update.
Okay, so we can't hear Alistair either now. Are you able to take us through the update, Kate?
Yep, that's fine. I can do. Just looking at the slide, all of this is in the report. I think what we just really wanted to emphasise was the importance of the network in pulling together the great work that's been happening across BCP. Sorry, I've just seen some messaging. And how the approach has really helped build resilience, help communities to set up new initiatives, and most importantly, to be learning from each other and not having everybody working in a kind of uncoordinated way. So it's about the infrastructure that sits behind this, so that we can really maximise the impact of everybody's efforts in this field. So working with the strength-based approach, looking at how we harness the work of partners, which has been fantastic. So we've got real sort of lead from a range of different partners, and the voluntary and community sector really stepping up, which is why Alistair was going to be so key to present this, because we've had some great generous commitments from the community and voluntary sector to lead this work. What we really wanted to focus on, and I think is outlined in the report, is the challenging times ahead around access to food, the related issues of poverty, and some of our more challenging areas, fuel, etc. So there's a wider challenge. But in terms of the Access to Food Partnership, I think really recognising the impact on income of some of the kind of changes that we're already seeing in terms of end of furlough, increased prices around fuel, etc. So it seems to us even more important to support this partnership, to maximise the commitment and the impact of what we're doing, and the report explains, I think, quite passionately how important that is. And I think the challenge for the board, not from a governance and funding perspective, because that's not the role of this board, but in terms of your role as leaders in this field, and a commitment to tackling inequalities as part of our board priorities, is to think about actually what can your organisations do to support this partnership going forwards. So if I move on to the next slide. The longer term sustainability of the partnership is something that we're working on. So BCP Council has put in an additional £30,000 as match funding for a lottery bid that we're looking at developing. But it'll be really helpful to really consider going forwards, how could we move this partnership onto a more sustainable footing? Is there any contributions that other areas can support? Also making sure that we work in a coordinated way around key messages. So are there parts of your organisations that need to be connected into this partnership to make sure that we're not sort of duplicating and we're really maximising the benefits of our work together? Also, the report outlines that there's, I guess, just some concerns that with staff changes, people leaving and so on, it's really important that we keep up the representation of public sector partners on the partnerships. I think public health particularly is mentioned. And just opening up really to the board in terms of thinking about is there other things that you would like the partnership to be doing? Would you like more information on or priorities or your information that you could feed into us? So hopefully that's okay. I'm sure I haven't done as good a job as the team themselves would have done, but I think it was just more about what's in the report and then opening up to a short discussion.
Okay, thank you for that. I think Alistair dropped off, but is now back with us. So let's see if we can hear Alistair. Is there anything you want to add to that, Alistair?
Yes, hello, Chair and colleagues. I don't know whether you can hear me.
We can.
Okay, I do apologise. I had computer failure, which is one of those problems of life we now think. So, Kate, thank you so much for being great, doing a great summary there. The only thing I was going to add is the balancing act is quite significant right now. On the one side, fantastic work that you and your colleagues on the board have done to help us get the messages out there. And there's superb work done at a local community level to make sure individuals have the food and the ability to cook that food that they need. But the challenge is getting harder, as the report outlines. Government help, the Household Support Fund will really help. But I just wonder if there are ways that you can maybe discuss now, if you have a couple of moments within the board meeting, to try and tip the scales back into balance, because this winter will be a very challenging one for individuals across our conurbation. So particularly that help around getting key messages out. If there's a way that this could be seen as core business, it's unfortunately one of those things that's everyone's business and no one's specific business. So where this can be seen as core business within what we do, then we're really going to make an impact on the wider determinants of health. Thank you so much for all you are supporting, and look forward to the discussion now. Thank you.
Okay, thank you. So I'm going to open that up to any comments from the floor. No, okay. So if we can move sort of straight to the recommendations then, which I think do support what's just been said there in terms of, you know, there's a lot of organisations in this room with quite a lot of good communication links to actually sort of push some of this message out and add their support to it. So I'm just going to go down each of the sort of recommendations there to ensure that people are happy with that as supporting those as the board. I'm not going to read them out in front of everyone. So is everyone happy with recommendation A? Yep. B, which is really around the communication, getting lots of nods on the Bs. C, for each member to identify dedicated representation from their organisation. So that would really widen the pool of this. Is everyone happy to do that? Yep. And D, to allocate again this item back on the sort of future agenda, which I think we would all support as well. Okay, so we'll take all those recommendations as approved, and thank Kate and Alistair for their time. Just going to go to Kate for a final one.
Hi, it's just to say I'm happy to be a conduit if people want to be in touch in terms of checking their representatives or following up, and then I can put you in touch with the team as appropriate.
Okay, thank you. And we've now got a couple of hands up, so I've got Sam first.
Yeah, thanks very much. I think it would be really good if we could just make sure that these actions are followed through onto the action tracker. I know we haven't got a lot of time on the agenda today to be able to have a full discussion, but I'm particularly interested in point A, because we are obviously going into an integrated care partnership in April 22. So it's just really to ask the board to think about whether this is one of those issues which we would put forward for the integrated care partnership to consider as one of the priorities. Thanks, Chair.
Yep, I think we can support that. And Councillor Rampton, do you want to come in?
Yeah, slightly similar point, I suppose, Chair. Thank you. It was really about sort of timelines. You know, we're agreeing to have a future agenda item, but we need to be quite conscious of how much of a problem this is going to be in the coming months with all the other issues that are happening at the moment. So are we going to identify a date that people will identify somebody from their organisation to be part of this?
Yeah, I'm getting lots of nods on that. I mean, I think we should certainly identify someone within sort of 1 month period. And it shouldn't really be so difficult for people to just feedback a name on it. So I'd say within the month. And again, lots of nods on that as well. Okay. So thank you again, Alistair and Kate, for presenting that. I'm going to try third time lucky now, because I know that Paul had issues and got kicked off as well and has come back on. So let's see. Can we hear you first, Paul?
Fingers crossed.
Yes, I can hear you. Right. So we'll go back then to item 6 for the Anchor Institution update.
Thank you, Chair. So a brief update from me. Anchor Institutions is a key area of work for our ICS level health inequalities programme. In effect, the Anchor Institutions approach provides a bridge for us between the core day-to-day business of key partners across the system and working on the wider determinants of health and wellbeing. So just a quick recap, Anchor Institutions' approach model encourages key partner organisations to look at how their purchasing, procurement activities might provide more benefit locally. Strong link here to the notion of social value. Second area is how buildings, facilities might be used to support local communities. Third area, working more closely with other local partners to spread good ideas, connect and work on the social justice, social value agenda. Fourth area that we would look to focus on is around reducing environmental impact. And the fifth area that people tend to focus on is one of staff employment. So both looking at how we might use recruitment to attract people into purposeful employment, paid employment, ideally, and targeting that on areas of deprivation, trying to raise aspirations there for people, but also perhaps looking at how we might use, as large organisations, staff volunteering as an opportunity both to understand and grow, develop stronger links into local communities, but also to benefit those communities at the same time through the volunteering work. So that's the Anchor Institution sort of model in a nutshell. I've been working with both BCP and Dorset Health and Wellbeing boards to try and get a sort of awareness raising session with the Health Foundation, who are taking a lead on this, particularly for NHS partners. And we've been unable to bring them into the boards as such, and agreed that it would make good use of time to actually set up a dedicated session on the topic. So at the end of last month, 29th of September, the two boards together, in effect, hosted a session run by the Health Foundation. We had over 40 people joining us, many of those key senior partners across the system. A number of people from this board joined us. And I guess that was well received, I believe. The end of the session, in the session we explored models of good practice across those 5 themes I've just described. And began to explore the idea of setting up a Dorset Anchor Institutions network to support partners take that agenda further faster. And it was suggested that partners be invited to sign a charter and then put forward people to join the network. And we've had initial sign up from a number of organisations to that charter and nominees suggested for an initial network meeting. So we're looking to run with that network meeting in early November, and currently just following up on the partners that haven't yet signed up or nominated someone for the network. So I think, Chair, it's an exciting development area, and one that we'll be hoping to make some progress on and report back to the board in due course.
Okay, thank you for that. I mean, it's an awful lot of interest at the events I've been at, and it's probably, you know, an area of the public sector we can actually bring an awful lot of sort of collective strength behind it, especially in terms of, you know, we're by far the biggest employers in the region, and effectively, you know, we've got a great reach. I think some of the communications channels we've got, and just some of the investment and employment opportunities. So I think it's something we can certainly do more on. Happy again to open it up to the floor to see if there's any other comments or anything people want to bring in. I've got go to Debbie first.
Thanks very much. Thanks, Paul, for the update. And this is something that within University Hospitals Dorset we're really excited by, and the opportunities to connect really well. I think they're for a whole range of reasons. Lots is happening. I picked up in another meeting that there was this presentation, and I said, would it be possible, because I think it started in the Dorset side, and then could we have it here? I'm feeling a little bit out of the loop of it, and that'll be my fault rather than anybody else's, because the conversations are taking place in a lot of different groups and different meetings. But could I ask that for where there's accountable officers, that there's a little note comes out on this issue, so that for organisations, chief officers, accountable officers, there's a little note saying this is where we are, can you formally sign up? And this is what we want to do, because I know I've got people represented in different meetings and they do feedback. We will need to make some changes within our organisation in order to respond to this appropriately. I think it's not a small change. I think it's a very big and important change. And we want to do this well. So I just say, as well as all the group work, I just ask for a little note through update directly to me if I'm the only one, but to other chief officers if there are others in the same position. Thanks.
Okay, thank you. Any other comments on that? Can you turn your mic off, Debbie, as well? Thanks. Any other comments? No, I think we can arrange for or ask Paul to arrange for just a briefing note for some of the chief execs and stuff. But I think that, as I said, there is a lot of support for this area, so I think everyone's very keen just to get behind it. Okay. So moving on then to agenda item 8 now. And I think on the line we should have Phil Hornsby, Kate Calvert and Becky Well to present on this item. I'm going to go to Phil first because his face has popped up first.
Thank you, Chair. Yes, so there's 2 reports, but the first one, and it's split in 2 parts, and I'll invite Becky to report on the second part of the Home First programme update. But the Better Care Fund is really Kate and myself to talk through the paper. So this is setting out where we are in 2020-21. We've just received the planning guidance for 2021-22, and we have to submit a plan by the 16th of November. And Chair, I've just noted that there's no recommendation on the report to say could that be delegated to Chair and Vice Chair with officers to submit this year's plan, because we'll be out of sync with Health and Wellbeing Board sign off, which needs to take place. What the report's setting out is a little bit of an introduction in the background. I won't go through that, but just to recognise that within the report, the impact that COVID's had on us over the last 18 months plus, and how the Better Care Fund has supported some of the work of the integrated care system to respond to the demands of COVID, particularly the pressure on NHS services and our acute hospital colleagues. There's some information in the report around the funding arrangements and the size of the fund, of the Better Care Fund and the improved Better Care Fund. And then it sets out, starting at section 4, around the approach to the 5 key operational scheme areas of how the Better Care Fund's been deployed. And that's been around maintaining independence via the delivery of equipment through the integrated community equipment service. Performance has been good in that area, but it has come under pressure, and there has been significant disruption to non-COVID related work in the community. So we've had some delays of people in the community not receiving equipment as quickly as we would have liked. But we have been able to maintain a really good support service to those discharged from hospital. And there is a budget pressure in that area because of the demands of COVID, but what that has been offset by is the hospital discharge funding, which we'll come on to in the next report. Maintaining independence was really about information, advice and guidance right through the whole of the system, whether it be in surgeries, pharmacies or businesses, to promote the website My Life My Care, which directs people to information pages, including things like food and meal delivery services, how you can access prescription services, care support, etc. Probably the key area is under 4.13, early supported discharge, and the working to the A to high impact changes set nationally. We have come under pressure, but the CCG been working with the national team, ESIST, which is referenced under 2 there, around the system pathways in and out of hospital and how we can make improvements, look at the length of stay performance, but also working around the additional capacity that we've had to bring in to support the system, including a rapid response home care service to ease some of the pressures, and how the system operates on a daily, weekly and other services together in a governance arrangement to manage the pressures as best we can. Reference there to carers, that we're undergoing a refresh of the Pan Dorset carers vision, which was really the high level strategy about how we'd support carers to both maintain their role, but to support them in the challenges of caring for their loved ones, and a little bit of information about the performance in there. Moving on from hospital living, which is the long-term care support to people who were formerly in campus provision in hospitals, and that's a privilege between BCP Council and Dorset CCG. And then the integrated health and social care teams, that's the bringing together in a multidisciplinary team, GPs, their practice staff, and social care and the voluntary sector, and obviously health staff, about how we manage people in their own communities. And then there's something about the market, and under 5, one of the key things the Better Care Fund's been used is to support the care market in these challenging times. We've been doing work around remodelling Coastal Lodge, which is a BCP owned care home, and that's operated by Tricuro, our local authority trading company, and we're remodelling that so it becomes an enhanced intermediate care service, which hopefully will in time ease the pressure on the system. And we brought in additional capacity funded through the hospital discharge funding for the brokerage services to have a care allocation team, which are linked directly to the hospitals, to our 2 acute hospitals, and support them with discharge and flow. And we're currently reshaping the reablement services, but there is some work to be done on a number of those areas to make us strong and sustainable for the future. We'll pick that up in some of the second part of this report when Becky comes in. And just the section 6 sets out the financial contributions to the overall Better Care Fund. And the risk in there is that we can rapidly overspend this money because of the pressures on the system. At the moment, that's been offset by the hospital discharge funding. I'm going to pause there, and Chair, I don't know whether you want to take questions on that section before moving to Home First, or I could ask Becky to pick up the second part of the report and then come to questions at the end.
Okay, I'd just check around the room if there's any questions on the first part that Phil's presented there. No, so let's move straight into the Home First programme with Becky. Are you with us, Becky? Is Becky with us?
Is she there?
No.
Should I just carry on, Chair?
Yeah, no, that's fine. Yourself and anything Kate wishes to add as well.
Okay, thanks. So the Home First programme is the Dorset System's response to the discharge to assess mandated requirements from government that were really in response to COVID. But D2A of Home First isn't new to the country, but it's fairly new to the Dorset System. So we introduced that approach following a mandate from the government to rapidly support the discharge of patients from hospital back into the community and assess them in the community, rather than the traditional approach, which has been to assess people in a hospital setting. We had some support from Professor John Bolton, who's well known and renowned for his work in this area across the country. And we are working now on the next phase of the programme to embed any changes that we've made to date, and really look forward to a sustainable model, for intermediate care. So those services that support people to recover after a stay in hospital or to prevent them entering hospital in the first place. And we've appointed as a system a strategic partner, that's Empower, who have done work on discharge to assess Home First with a number of organisations across the country, probably most recently with Somerset Council, that's the Somerset area. So the focus to comply with the national requirements, when the criteria to reside in hospital or no longer reside in hospital, how we implement the requirements of that includes daily board rounds twice a day, having a single point of access, so all referrals out of hospital come to that place and are then triaged and directed to the right place. A multidisciplinary team assessment out of hospital, having a case management approach so you know who is supporting you or your loved one, and joining up intermediate care across the local authority and health services. And we've got to understand the data. I'm not going to go through these bullet point by bullet point. The key really is how we develop a future model and commission that model so that we've got the right capacity of commission services, that we really focus on recovery and get people to either back to the state they were, the baseline they were before they entered hospital, or at least as good as they can be, so it reduces the need for long-term ongoing care and health services. And it's really a lot of it's about improving the process. There are quite a few handoffs in the system, and we need to reduce that and remove delays and have a collaborative delivery model right across all partners. And really, this is about integration of health and social care into a model that becomes seamless. So what did we have to do? We've appointed a system flow director, and that is Becky. And Becky's job is to coordinate all of the actions and really to improve the flow. It's in the title, flow director, and link with the urgent emergency care board. As a reference, we've appointed Empower to come in as a strategic partner. They're in the first phase of their work. That's just really looking at our current processes. How do we work? What could we do? What they see is blockages or areas for improvement, and what would be the high impact changes they would recommend to address our immediate flow issues. And there were some priority interventions that were agreed by the Home First board in September, which we've which we have and are in the process of implementing. A winter proposal, a winter plan, so how we extend the short-term rapid response capacities, that's that home care service that I referred to earlier. A focus on capacity in end-of-life care, because we've identified that as a gap, and what scope there is to open additional interim beds, but with the capacity of therapy and re-ablement to support people to recover. And we have linked the hospital discharge funding into that. And there's the reference to the therapy workforce as being key to improving the work. There is a limited workforce out there in all areas of the NHS and social care. So we have to get people to the best place they can be in order to reduce the demand on long-term services. Metrics are key. At the moment, we haven't got a single view of all of the processes and following that patient through from hospital, through that intermediate care service, and then back home. So we're still working on that. Empower are helping us and using the work they've done in other areas to help us. And then the final part of that is the progress made in the development of an urgent community response. And this is a national expectation, part of Ageing Well agenda, but does link very clearly into Home First. Because if we can prevent people entering hospital, then that will support our acute colleagues. In terms of performance, and this is not the best picture in the world that we're going to paint. So the system flow is a challenge. We've got more people waiting in acute and community hospitals than we would like. And there are some numbers in there. It's a particular challenge for University Hospitals Dorset, and that P1 discharge, and just to explain, that is really the recovery pathway. That means pathway P1, pathway 1, and that's that discharge home, but with therapy input and re-ailment support in order to maximise an individual's independence. And we've got delays of people in the community hospital beds, but we're doing work right now to free up those beds to improve the flow from acute hospitals to community hospitals. I referenced workforce before. We've got increasing waits for home care support and numbers of people waiting large packages of care. That's not just in hospital, in community. In the community, we've got increasing numbers of people waiting to access care for the first time, or for increases in packages. And that's a significant risk in the community. And there are similar backlogs in community therapy services. There is some capacity in care homes, but there is limited staffing. So you can see big numbers of care home beds available, 500, 600, but actually there's only staffing there for probably less than 100 because of recruitment and retention difficulties. And all of the above are contributing to the issues around flow in the system. And there are some charts there that just show that the way that the numbers have grown around medically ready to leave patients. If we overlaid that, there has been a lot of work. We've never bought more care as a health and care system in the independent sector, but we're just not keeping up with the demand, and that all comes back to workforce. So for the next quarter, we'll progress those priority interventions, implement the winter capacity plans to improve and maintain flow over quarter 3 and quarter 4. We need to refresh the financial framework to support hospital discharge. Programme 4, that's the subject of the next paper, and apologies for the acronym. But we really need to start to think. We expect the funding to end in March 22. We really need to transition to a long-term sustainable funded model. That's partly the work that Empower are doing with us to help that. And just look at the programme governance and look against our position against the national guidance to make sure that we're compliant with that. And then just the work with Empower around the long-term model. I think that's it, Chair. Sorry for taking such a long time to go through that, but there's a lot going on.
Okay, thank you for that. Could just check with Kate. Is there anything you wish to add, Kate?
Thanks, Chair. I think it's just to comment that actually this is a significant program of change that we've been trying to implement whilst we're still managing the pandemic. And as Phil said, the workforce pressures are exacerbating the situation. But everybody certainly is working, very hard to make sure that we can manage the pressure. Thank you.
Okay, thanks for that. And I just echo the points that's been made there. Really, that there has been a huge amount of work that's gone on in this area, and it's been really at pace as well, with a lot of short-term funding mechanisms being added on, and just trying to find our way through an incredibly challenging period. But I think this is what's said, we are not keeping up with the actual the discharge flow that we actually need, which I won't delve down into that, because the next agenda item is on the hospital discharge funding and that programme itself. But we can just see the pressure across the whole system as a result of that. I'm going to open up to any comments in the room. I've got Sam first, then Debbie.
Thanks very much, Chair. Thanks for taking us through that, Phil. There's clearly an awful lot of work going on, and it's a complicated area, and obviously you get the sense from the report that the demand is unprecedented. I guess my question was really thinking back. We've had the Better Care Fund now for several years. How well do you think we are currently working as a system? Because I think that's critical, isn't it? There's a huge change agenda, as you've outlined, and I guess I'm interested in how well we're tackling that from a system. And sometimes I am concerned when I hear phrases like it's focused around the discharge from the hospitals. Obviously there are lots and lots of people in hospitals, but I'd like to hear more about the strength of community services that maybe are preventing some of that demand going into hospitals in the first place. And I know it's not a normal system in the sense that we've had COVID and we've had all of those extra pressures, but I'd like to hear a bit more about perhaps the integrated locality teams. What's the situation outside, and what are those alternatives to what is an extremely pressured workforce, isn't it? You've described really well some of the difficulties with the professional roles, particularly therapy, but where else can we go to think differently to try to get a different result, because it's an extremely difficult situation. Thank you.
So I'll start, Sam, and then I might ask Kate to come in about more about the community response, particularly around the health elements. So you're quite right. I did highlight the elements around intermediate care and that therapy rearmament response. I think a more integrated approach to that is the goal. We've recognised that for a couple of years. I don't think we've really got to it and got under the skin of that about what we need to do. But that is one of the focus of the impact work, and the CCG and the local authority are as one in this. We both agree about how we need to change it. We just need to get the model right. I think the bit that's missing, probably hasn't been highlighted enough in the report, is the role of the voluntary sector, and how we can use them on the support to people who have had a stay in hospital and don't necessarily need those intensive health or social care packages of support, but could benefit from some short-term intervention, some help home from hospital, or actually some preventative intervention in the community. So the community working with people who might be at risk of deterioration, and then that leads to a crisis and they fall, or they something happens in their life that means they need to go to hospital. I think what we really need to focus on as well is our information as a system, how we understand what's going on, and we can track people and really intervene earlier. And I think some of the population health management work will help us in that. But I'm just going to pause there and ask Kate if she wants to talk a bit more about the community services elements.
Thanks, Phil. Sam, you're quite right that it's so important for us to not lose sight of the work that we were doing prior to COVID through our integrated community and primary care investment. And we're picking that up again through the Ageing Well program. So we've got a focus not only on the urgent community response, which will deliver at scale, but also at a local sort of neighbourhood level, because we think it's important that that happens at both levels. We're looking at anticipatory care and how we deliver on that within the neighbourhood, working across health, social care, voluntary sector within communities, and hopefully we can develop a bit more of a local flavour with what we do around our models of care going forward. What COVID did do, and the pressure on the system, is just meant that we had to shift our resource to focus on supporting those out of hospital. But we certainly are taking that back and moving it forward in terms of the anticipatory care approach.
Okay, so I'm going to go to Debbie Fleming, then we have Louise Bate online after Debbie.
Thanks, Tim. And I mean, firstly, I'm just really pleased that Health and Wellbeing Board is focusing on this issue, because it's so important for all of us. It's so important for our population. It's one of the subjects, whenever I see it on the agenda, it makes my heart sink, I have to say, because I think we all feel really frustrated at so much hard work going in, lots of really good people doing lots of really good things, and we're not really seeing the results that we should for all of the effort, is the truth, and all of the expenditure. So if I can do a couple of things, Tim, if you can indulge me. One is to share my sadness and frustration for just a couple of seconds, then to think about some of the things we need to hold on to, and then just really wanting to reiterate how much we all want to work together to get this right. So if you just look at that chart under section 7.4, and for me and my colleagues in the hospital, the worry that we have about all the people that don't need to be there, let us remember what that means for those individuals, and that they are deconditioning in the hospital. We know that for as long as they're staying in the hospital, they are not recovering well. They are likely to lose muscle strength. They are likely to lose confidence. They will go downhill. So when my mother was in hospital, I didn't want her in. I didn't want her in. No, I'm obviously brilliant services. Didn't want her in. And I wanted her out as soon as possible, because I didn't want her to go downhill. And that's what has to drive all of us, is that the hospitals should be just taking people for a brief moment, getting them back home as quickly as possible, or to the best care that we can. It is serious leaving people in hospital. And sometimes people think it's a place of safety, or they think that actually it's better, so at least they're there, at least they're safe. No, they have a big risk of falls. They have a very big risk of infection. And we've seen tragically with COVID how awful that is, the risk of infection in hospital. And we've all seen that very starkly. And this is now being normalised. Increasing delays is becoming normalised. We're talking numbers which are unthinkable. And I can't tell you how dreadful this is, and how I will not stop with my colleagues and with all of you to try and to put all our energies into improving the situation. So enough on that little note. When I stand back from it, we had a board development day yesterday in the midst of all of our busyness, and we were reminding ourselves about some key principles looking ahead. And we absolutely must focus on admission avoidance. So all the things that Sam was saying and that Phil and others are saying, sometimes people say everyone's got a bed. I know not quite everybody does, but most people have already got a bed. So actually, if we can avoid people having to come into hospital in the first place, we will not have to worry so much about getting back out again. So the emphasis has to be about developing our services outside the hospital. The teams, you're talking about the integrated health and social care, locality teams, they're the key to success. They need to be properly resourced, properly recruited to, and functioning at the top of their game. So there's a lot of change in all of that. We must keep people out of hospital. The other thing that came through yesterday is we should really be working to avoid elderly medical emergencies. Now, I know that's an ambition that you'll never totally avoid that. People have strokes and people have all sorts of things where they need to come into the hospital. But we need to get our chronic disease management absolutely right, that we're really doing everything on a planned basis out in the community and individuals are empowered to look after themselves, so that we get that bit working really well. and try and get into a place where everything that we can that's an emergency turns to a plan as quickly as we can. We're doing a lot on same-day emergency care in a whole range of places, and in medical work and in surgical. We have already, as a system, committed to investing in 7-day robust community services. That was our priority a few years ago. It's still our priority. We need to refresh that strategy and really make sure that happens so that people only come into hospital when we want them to come in. And we must ensure that we've got a clear and robust response to social care emergencies, because too often things crumble, as we know, because the very last bit has gone, or we can't get people out because of it. We don't want people in hospital for social care emergencies. We want them in for medical emergencies, and we don't even want that. We want everything planned. So against that big strategic backdrop, I'm looking forward to working with partners to develop our future strategy to refresh all of that. We've had a lot of change going on, and we've had a pandemic. We're spending shed loads of money together, so let's spend it to really good effect. Because I look back, and where are we spending money? We don't want it spent in that area. For me, top of the list is keeping patients in hospital who don't need to be there. And at the moment, 20%, and I want you to hold that figure, 20% of my beds are taken up with people who have no reason to be in hospital. That costs us, I'm worried about quoting the figure because I'll get it wrong, but it is millions. So let's all work together to do the right things for each individual, for all our elderly patients who deserve the best, and encourage them to be able to do the best. We all want to do the best for ourselves, but there are lots of opportunities, but I cannot emphasise enough the seriousness of this. And it's all about early intervention and prevention and getting it right first time. So still working with you on it, gang. Thank you. Thank you for indulging me, Phil.
Thank you for that, Debbie. I just echo the points that Debbie's made there, that you can see the drop off at weekends, which means effectively that the hospitals are clogged up again from the Monday morning. It takes us all week to clear, and the muscle wastage of people, particularly with the elderly frail, when they go in, sat in a hospital bed or a hospital chair. It's not where you want them. They're not effectively getting up, making the cups of tea, walking the dog, going to the shops or whatever. If you're just sat there, and as much as we've got the rehab teams in the hospital to help support that, it's a hospital ward at the end of the day, isn't it? There's only so much there. So I'd echo what Debbie has said there. Let's go to Louise, then I'm going to move us on to the next item. I'll take Karen Rampton as well, as she sneaked in at the end. But Louise?
Thanks, Chair. Thanks for the report. I agree with Sam and Debbie's comments. Really, I was keen to see how Home First team are gathering people's experiences of the service that they're getting at the moment. Because I think it's really crucial that we listen to what people are experiencing right now and what they would like to see in order that we design a service that suits people's needs better.
Are you still with us, Louise?
Yes, could you hear me?
Yeah, no, we did. No, we thought you'd frozen there at the end. Sorry. I think it's that. So the question really was listening to the services and people and patients, and just some of the reports coming back. I don't know if you want to comment on that at all, Phil, in terms of getting people out and what people are saying to yourselves.
Yeah, I think it's a gap, Louise. I don't think we're systematically asking people how it's been for you in that journey. We've been so inundated with a demand that we're not standing back from it and saying what was it like. We've done a little bit, but we're not doing it systematically, and we're certainly not capturing it in a way that we can then report on it. Perhaps it's something we could ask Healthwatch to help us with.
We'd be happy to help, because I think it's really crucial to get the service working in a good way that meets people's needs.
And the other thing I don't think we're capturing well enough is the outcome or the impact for that person. So it is about their experience, but it's also what difference have we made to your life? Yeah. Have we got you back to independence? And I would just want to pick up on the same point about we know people decondition in hospital, but they also decondition at home if they don't get the right therapy input in the community to get them back to independence. You can sit in your chair all day and see the people 2 or 3 times a day that come and do a bit of personal care. That isn't good for you either. So absolutely echo what Debbie said. We've got to get in that prevention and early intervention and balance our focus, both looking to the hospital to support people home, but preventing them coming in the first place. So thanks, Louise. I think we'll have a conversation.
Thanks, Ray.
Okay, thanks for that. It would be a good area actually for Healthwatch to look at, because it's one of those sort of hidden areas, isn't it? Really, you know, it's not a big shiny hospital that you can see, touch. It's not a GP practice or stuff. So yeah, it is more difficult for people to see and get the feedback, and people that are going through that sort of discharge process. So that would be good if that could be followed up. Councillor Rampton.
Yeah, thanks, Tim. I just wanted to pick up on a couple of things that that Debbie said actually, and Debbie, you said that people get sick in hospital, and we know that, and but when people are discharged from hospital into care homes, not just the community but in care homes, it's well publicised what happened when we were at the worst part of the pandemic. So discharging people into care homes is also an issue. So you're absolutely right when you say what we have to do is admission avoidance. And that's what it's all about, in avoiding those emergency admissions. And I just wanted to say, and I know that I have mentioned this before to Tim actually, which is about when I met with somebody at Warmouth University recently, we were talking about the health and social care sort of programmes that they run there. And they were saying that this year they're 30% oversubscribed on those programmes. And I thought that was amazing. I said, that's fantastic. It's really good. It doesn't help us now, but in 3 years' time, it would help us. But the problem is they can't take on that number of students that they could. We desperately need those physios, those OTs, those social workers. We need all those trainees, but we can't take them on because there aren't enough mentors for them. And that just seems to be a fundamental issue that we should be looking at. If we have the mentors in place, and I know that everybody's working at capacity at the moment, and that's not easy, and I'm by no means a health professional, I don't know quite what's involved in being a mentor, but if we were able to increase that mentoring for people, the universities could take on more, and that throughput in 3 years' time would be there, and we'd have those people to support our residents in their community.
Okay, thanks. So I think it's a good point in the mentoring, and it is a limiting factor when we take on some of the nurses, and some of we've done some local nurse apprenticeships in Dorset, and we're now on our 3rd year, so we've got 152 sort of nurse apprenticeships, and we'll start to see the first ones coming out of that. But the limiting factor on that was you need mentors for each one of them, and that's on top of the national one, and that was what was limiting us as well. Did you want to come back on that, Debbie?
Just very briefly to say, you're absolutely right, and we have very significantly expanded the number of mentors. Literally, I don't recall the figure, but massive expansion in the number of people, and we've actually changed things so that 3rd-year students are involved in mentoring before they actually finish, to try and maximise what we can do. What we have to do though is to make sure that every one of those learners has a good learning experience, and if we get that wrong, if you don't have the support and you're put in a position when you feel overwhelmed and being asked to do things that you're not capable to do, then we'll lose them. The attrition rate will be high. So it's absolutely been expanded, and it's been challenged across the whole of Dorset on several occasions. Everyone's done everything they can to do more across all of the institutions, and they've maxed out what they can safely do now, and give people the support they'll need to do the learning. So it is frustrating, but we've got people coming in from a lot of places, overseas, different learning routes now, and our staff can't take on any more. They just can't. But we have expanded the number of places, and I can let you have the figure outside the meeting, Tim, the number of mentors expansion.
Okay, thank you for that. Councillor Kelly, did you want to come in? This will be the last one, and then I'll go to the recommendations.
Thank you. I'll be very quick, Chair. Thank you for letting me speak. So normally I'm not here at this board. I'm a substitute, and I think I absolutely agree with everything everyone said. And the need for prevention of people going to hospital demonstrates the link between our communities team and this board, and public, health generally of our residents. Because as the Chair will know, we're embarking on a real push to provide asset or strength-based community development work, and this will, when we get our full team recruited and on the ground, and really what they will be trying to do is to talk to residents, to find out what those needs are, to find out what the strengths are, and just to provide and enable sort of low-level groups support groups, skills groups, little knitting clubs, you know, and choirs and different things that people want to do, or get them out of their house if they're able to, and to feel part of a community. And those kind of low-level supports can often raise the sense of well-being and self-esteem, and enable people to feel better and help each other to stop that need of going to hospital. So I'm hoping that over years, over time, it's not going to be quick, but this work that we're going to be doing will really make a big difference. And I know that there's probably some officers on the call here who are very supportive of this approach. Thank you.
Okay, thanks for that, and I'd echo that as well. The more you can do with communities and families, the better, really. And there has been some great standing up examples of that around the country and around the world, actually, in terms of how some of the communities can make a huge difference in terms of that process. Okay, so we've got three areas that the board is asked to note. So that's just around the performance of the plan, the revised guidance, and the progress that's been made with the Home First programme. So that's just for the board to note. We're going to go back to the point that was introduced earlier. That we're also being asked to delegate the sign-off of the Better Care Plan to the chair and the vice chair due to the timetable that's now been put upon us. So I'm going to look to any support on that.
Chairman, if I can just make a suggestion, I think Mr. Hornsby's indicated the formal wording in the chat, so if you're happy for me to read that out in relation to that delegated authority.
Yep, that's fine.
The board can consider that in addition to those points to note. Basically, a recommendation to delegate sign-off for the 2021-22 BCF plan to the chair and vice chair in consultation with the portfolio holder for adults to meet the 16th of November deadline.
Okay, do we have support for that? Yep, okay. Thank you for that then. Should we move on then? This is very closely related. So agenda item 9, just the hospital discharge programme, and it's back to Phil again.
Thanks, Chair. Just catching up with myself because I moved to the top, back to the recommendations. So sorry, I've got the paper now. Thanks, Chair. So the hospital discharge programme funding is some grant funding that was introduced by the government last year, and it's gone through a number of iterations. We're on programme funding 3, and that was the last period. That was the 6 months from April to September. We did agree at the June Health and Wellbeing Board that we would bring a full report back around the reconciliation of that, but we haven't, unfortunately, been able to reconcile the funds in time for this board. It's work that's going on between the CCG and the local authority to get those numbers landed that link back to the £8.4 million worth of funding that were allocated to ICS, so that the whole of Dorset at the early start of the year. On the 6th of September, the government did a press release that said there was going to be further hospital discharge programme funding. We got our allocation on the 4th of October, so very recently, and that's just under 9 million for the second half of the year. And we're developing a plan about how we progress that and use that money effectively to support as everything we referenced in the previous paper and the comments that have been made. The paper really sets out some background, which I'm not going to take any time on. We're looking the Dorset Home First Board, which includes senior leaders from across the health and care system of Dorset, continues to look at the options and service models to meet the significant challenges that we've just spoken about, and supporting people to have that swift and safe discharge from hospital. That links back to that Empower, bringing in Empower as a strategic partner to help us with that. We've, in order to comply with the mandated requirements of the hospital discharge programme, we have moved to a 7-day-a-week working, but we do recognise within that isn't helping the flow in the way that we would hope, and there are pressures, particularly on weekends, even though we do have qualified staff working, whether they be social workers, health professionals or brokerage, right across all 7 days and extended hours. What I did want to just focus on is some of the risks. So under 15, and it's just a one paragraph in there, but the real risks around here about the sustainability of our costs in order to support the demand, the very high demand that we've got at the moment. We are trying to work together to deliver that, but there is significant pressure right across the whole of the system, and particularly in hospitals at the moment. I think the financial implications for us are that if we don't get the sustainability model sorted out for the long-term funding approach, this significant funding that we've had this year, which will be over 17 million in total, won't be there. And we have to find a way of a system that can cope with the pressures and the long-term ambition to have a discharge to assess programme and make sure that people are in the right place to receive their care and not in hospital when they no longer need to be there. If we don't get that modelling right, we each face significant financial risk. The funding for local authorities, the only way that we've been given funding to support social care is through the council tax approach and short-term grant funding. We would hope that the comprehensive spending review and the health and social care bill, or the social care bill that's expected imminently, the white paper, will put us on a longer term strategic funding footing. I think I'll pause there, Chair.
Okay, I think we echo the points there, and particularly the risk that some of this funding, it is going to come to an end, and we are going to have to revert back to previous mechanisms, and that does create a cliff edge for us if we've not got the flows going correctly through the hospitals and out the end. It probably is worth noting that the actual number of referrals into our hospitals are actually slightly down, but what we are seeing is the actual acuity or the complexity of the patients is up, and that is creating more difficulties at the discharge point, with more complex packages being requested, and trying to meet the demand on that is proving incredibly challenging. Not just in this area, but we're seeing that right across the country, and particularly across the southwest. And the workforce challenge that we've already mentioned is really impacting now in this area, and we are struggling with it. I'll open up to the floor if there's any comments or questions people want to come in on. So I've got Debbie Fleming first.
Very quickly, just wanted to say about the workforce issues that and we've already said we need to be developing a sustainable long-term model that we can afford, that is high quality, but also that we can recruit to. And so, we need to look at those models, make sure they're good models, that we've got people working in teams, that they feel supported, that they come able to go home at the end of the day feeling they've done a good job. Really critical. The other critical link, which I know people know, but I want to say it again, is about affordable housing and key worker housing, and making sure that we're thinking through, and really, because other systems are doing quite a lot on this. I know people know it, but I just want to say it again, being able to offer people somewhere to live, to move to the area, is a real big feature. And in a whole range of ways that I'm not an expert in, but key worker housing is something that should be on our strategic agenda as resolving some of these issues.
Okay, any other points anyone wants to make? No. Okay, so I'll move to the recommendation, which is similar to the previous one. So we're being asked that there's an extension to the period of delegated authority for the chair and the vice chair of the board, following discussions with the cabinet portfolio holder and subject to council and CCG governance processes, to make relevant decisions on behalf of the board related to the Dorset Integrated Care System funding for the hospital discharge programme for the period up to the end of March 22. Is everyone happy to support that? Yeah, so we're getting nods on that, so we'll take that as approved as well. Thank you for that, Phil, and appreciate there was a lot to take in there, and it all fell on you to present it. So thanks for your contribution there. So we'll move on then to agenda item 10. This is the update on the Dementia Services Review. We've got Mark Harris here from the CCG to present on this item, so I'll hand over to Mark.
Okay, thanks, Chair. So everyone has a copy of the report, which I'm just going to do a quick canter through really and just take out the key highlights. Previously, you will have had some stuff come through to the board around the Dementia Services Review, which was undertaken back in 2018-19. The implementation was delayed because of the COVID pandemic, but pleased to say that we were able to start that implementation from April 2021. The report takes you through where we've got to in terms of that implementation. Similar to the previous item, we have struggled with recruitment and workforce initially, but pleased to say that that now has sort of been resolved within the memory assessment service specifically. The new model really sort of opens up an open access referral system, so it's a single point through the memory assessment service for anybody that needs to have a diagnosis, and strips out what was there before. As I said, there was another step before that. It also brings in a new workforce model, thinking about the workforce challenges we've got, where it's not just reliant on psychiatrists, but actually using advanced nurse practitioners to undertake less complex diagnoses. So the key elements of the new pathway of care really are the memory assessment service, which is around diagnosis. A key element around post-diagnostic support is the dementia coordinators, which I'll talk a little bit about in a second, alongside other elements of cognitive stimulation therapy and carers emotional support. So the diagnosis aspect obviously is a key element for us, and what you will see in the paper is referrals have been impacted quite significantly over the last year. During the first period or phase of COVID, we saw a significant decline really in referrals coming through to the service. But then as of March this year, which was when the new model has started to come into play, we've seen quite a big bounce back in those referrals, which has gone above those numbers that we modelled originally in the Dementia Services Review. So it does create some pressures for us. One of the aims of the review is to cut down waiting times for diagnosis, but also to improve our local diagnosis rates. Pleased to say that that seems to be plateauing out a little bit now. In the last couple of months, we've seen the referral rate start to plateau back down again, which suggests that sort of backlog through the pandemic is potentially or is known to the service now. Just to say, as part of the sort of the backlog challenge, we have been allocated some additional one-off funds through spending review to be able to address the backlog of numbers that are waiting, and we've again successfully recruited some temporary staff to sort of increase the capacity within the diagnostic service to try and get through those numbers. In the paper, you'll see a sort of a graph with a trajectory on it, which sort of gives you an indication of where some of that is at this moment in time. The other key elements, the dementia coordinators will be a significant, really important component of the pathway moving forward, and that's being provided by Help and Care. So again, they're embedding themselves within local primary care networks at this moment in time and really becoming part of local primary care multidisciplinary teams. We're also tying in with the social prescribing offer that's already out there as well. So again, thinking about previous comments around how we sort of join different parts of the system together, that's the emphasis that we have within that. So their numbers have steadily increased. We had obviously a big jump through in April when they first came onto board, sort of into place, and now we've plateaued out sort of with new people coming through in the last couple of months. Cognitive stimulation therapy is also being put into place alongside the carers emotional support groups. One of the challenges around that is obviously the sort of the COVID restrictions around meeting with people. So again, thinking through digital sort of opportunities to be able to deliver them, but also looking at how we do that in a safe manner through face-to-face means. The other component is around the intensive community support offer for dementia. So previously we had that service, but only in the east of the county, and that now is rolled out across the Dorset. So we've got equity across the county for the whole population. Just to pull out sort of the other key point really around diagnosis rates. Our system has always been challenged with hitting the national threshold, which is 66.7% of the predicted prevalence rate within the county. For many years, we've sort of tried to sort of hit that, but not quite got there. Obviously, things have gone the other way in the last year, and we are back down now into the 50s. But that mirrors the national picture. And we are pretty much in line with sort of the sort of trajectory of how things are looking in the national sense as well. But it's something that we will need to continue to work through and work with colleagues across multiple teams to see whether to make sure that we are identifying anyone that's out there that may have a memory problem. We're hoping that one of the outcomes that we want to see from this new pathway of care is that will make it much easier for people to sort of present. And we're working with rural communities as well. We recognise that actually there's lots of concerns out in the rural, so thinking about farmers, their livelihoods being at risk if they come through and get a diagnosis. So we're trying to work with sort of the Farmers Alliance to sort of try and encourage people to come through there as well. Lastly, just to point out that the plan will be to evaluate the impact of the new model of care. We're aiming to obviously have that in place at least 12 months to get a sense of whether it is having the difference that we're predicting. What we will need to understand within that, though, is how it is sort of differentiating the impact of COVID from the actual new model of care. I'll leave it at that, and I'm happy to take any questions. Thanks.
Okay, thank you, Mark, for that. So I'm going to open that up to the floor. If anyone got any questions for Mark or any comments on this, which has clearly been quite a challenging area, and it was something that we focused a lot on pre-COVID to actually do the review and sort of get this off the ground. So it's pleasing to see it's gone off, but obviously it's had an understandably difficult period in terms of the actual launching of this. Richard Jenkins.
Thanks, Tim. I just think it shows how everything's joined up. I suspect lots of the people sitting in UHD are actually have cognitive impairment or undiagnosed dementia, and that leads to the crisis, which lands up in hospital and then delays the discharge. So, I welcome the new pathway and speeding up diagnosis and increasing capacity, because I think what we need, as Tim and Mark have pointed out, it's been an issue in Dorset for a long time with low diagnosis rates, and hopefully if we can be a bit more proactive and make more diagnoses, we can have beneficial effects down the line. Thank you.
Thank you. Any other comments from anyone? Yeah, David.
Thanks. It's good to see that the carers emotional support workshops are gearing up now after the pandemic, and I'm sure the last 18 months have been a very difficult time for people who are carers. Somebody with dementia. I just wondered what additional sort of post-pandemic support carers might get, and particularly whether the dementia coordinator service also supports carers.
Yes, I mean the dementia coordinators are open access, so people can approach them. They don't have to go through a GP for referral to them. And I guess the point of the dementia coordinators is to support the individual and their family. So it's about helping them navigate the systems, which are complex and myriad, from the time that they're starting to have memory problems all the way through diagnosis and to end of life. So it is around a family response. It's not just limited to sort of the individual itself. And I guess the bit that Richard, I suppose, is just referenced there, it is around actually making sure that we've got access to all the other services that are out there. So it's not about the coordinator doing the actual intervention, but making sure they know where to go to take people to it. So yes, the offer is there.
Okay, any other comments? No. Okay, well, thank you for that. The paper was just for noting. I think it's one that we'll come back and visit at a future point as well. Can I move us on now then to agenda item 11, which is the Safeguarding Adults Board Annual Report. We've got a very comprehensive report in front of us, so we'll take it as read that people have seen that and gone through it. But I'd like to welcome Sian Walker McAllister, the chair of the Safeguarding Adults Board. It's her first meeting of the board here today. So I'm going to hand over to Sian just to introduce and just pick out some of the highlights from the report for us.
Thank you very much, Chair, and I'm pleased to have the opportunity to present this report, although this isn't my report in essence. This is the report of the outgoing Chair, Barry Crook, as this annual report covers the period up to March, the end of March this year, and I joined the board at the end of April this year. So if we, Claire has got a presentation and she's going to put that up on the, thank you very much, Claire. That's lovely. If we can go to the slideshow, that's great. That's fantastic. So if we can go to the next slide, please. So the BCP Safeguarding Adults Board exists as the local authority has a duty under the Care Act, and the local authority is indeed the lead for safeguarding adults. And I should also mention that the statutory partners are the council, the Dorset Clinical Commissioning Group and the police. So those are the three statutory partners, but we have other partners on the board, and they're listed there, and also the prisons. We're working closely with HMP the Verne, and then over this coming year we'll be working to make sure that all the prisons across the patch are involved, because people from BCP may also be located imprisoned in any of the other prisons. So we have Health Watch, representatives from the voluntary sector, the DWP, fire and ambulance, all the hospital and healthcare providers. And the BCP SAB works very closely with the Dorset Safeguarding Adults Board. And in fact, we had a recent meeting, although not covered in this report, where we agreed that it would make good sense, would be an efficient way of working if we joined the boards together more. They already share common subgroups. And if we retain the ability to hold place-based BCP meetings where those might be absolutely necessary. So if we can move to the next slide, please. So the board has three statutory duties: commissioning a safeguarding adult review, often known as a serious case review, when someone has died, but the board can at its discretion commission a review where it feels that there are serious circumstances and there is a need to undertake learning across the partnership, and to agree a strategic plan every year demonstrating how it's delivered to the partners. And we should also publish an annual report and deliver the annual report to this meeting. So the next slide, please. Next slide, Claire. Claire? Something's happened here. I'll go on to mine. Oh, lovely. Thank you. So our joint strategic plan for this annual report was one which was created in 2018 and ended this year. And the plans are set out there in terms of working with the care provider market, closer working around domestic abuse and safeguarding, and committed to a process known as whole family working. And that's really, really important. And in fact, going forward, I'm going to be having a meeting in the next week or so with the new chair of the Children and Families Partnership to see where we've got areas of common ground and where we can be taking work forward in our strategic plan for this current 3-year period. Very importantly, ensuring that lessons from safeguarding adult reviews impact on changing practice. So it's a real responsibility of the board and its members to assure the board that there are changes being made, so we would not see a repeat of circumstances and situations that we've already investigated and have already set out some learning. We've already agreed a joint business plan going forward, and the priority themes are safeguarding in the care sector, domestic abuse, neglect and self-neglect, and all the issues set out there. You'll have read the report, and those are set out in the report. In particular this year, and again, not covered by this annual report, but important to set out, we want to be looking at transitional safeguarding. That's safeguarding for children and young people who've been known to have suffered neglect and harm into adulthood, and where we pick up as they move into adulthood any issues and prevent them from safeguarding incidences occurring. If we can move on, please. So we've made progress on the plans for last year, and those are set out below. Partner agencies have worked very closely with the provider market through the pandemic, and we know that there has been some really good relationships and good working established, and I think all of the care sector will say that and the board has been assured that during the pandemic the council has worked very closely with them, as has the CCG, on delivering good relationships to ensure that the most vulnerable are supported in the best way possible. We know that government published yesterday, or the day before yesterday, a report on learning from the pandemic. And we're certainly seeing now new learning emerging from the pandemic going forward. And in fact, this year, we're going to be having a special board meeting convened where we can look at further learning around safeguarding and care quality that has emerged during the pandemic period. So the SAB has continued to work with the Community Safety Partnership, and those relationships are particularly important around domestic abuse and the domestic abuse strategy, but also in terms of other issues around exploitation, and where the board can ensure that issues are covered that may also involve those with care and support needs, and we can work together efficiently so that we're not duplicating any work, and that's something that together with senior officers with responsibility for community safety in BCP and I have been talking about recently in terms of taking the agenda forward. Whole family working is embedded well into training and working practice, but we'll continue to make sure that practice improves. And the SAB has continued to work on actions arising from safeguarding adult reviews, as well as on an unpublished safeguarding adult review from the previous year. I would say that our default position is always to publish safeguarding adult reviews in the spirit of openness and transparency, but there are some circumstances where relatives and people are still alive and when it's not in the public interest or in the individual interest to publish a review, and the board will collectively make that decision as it considers those reviews and the output of those reviews. Working with the local authority, steps have been taken to understand safeguarding categories of neglect and acts of omission so that preventative work happens. This is the single most prominent issue in terms of safeguarding, not only in BCP and in Dorset, but across the country. And we all have much to do and work towards doing preventative work around neglect and acts of omission. The SAB's focused on homelessness, and there's been some excellent work that started in the period of this report and continues within this year. We've just had a business planning meeting where BCP and Dorset councils presented together on the work that is going to be happening, which focuses on some national reviews of homelessness and safeguarding. The Safeguarding Adult Board participated in a nationwide project run by Alcohol Change UK, and it continues to be a focus for improved preventative work. We had a recent local event around legal practice that can be used to support people and the appropriate relationships that can be undertaken with people who misuse alcohol, and how if we do that better, we can do more preventative work. So the next slide, please. Of course, the primary reason for a Safeguarding Adult Board is not just to review things when they've gone wrong, but importantly to work together to ensure that priorities and procedures are aligned so that we can prevent safeguarding incidences happening, and that's certainly going to be a focus over the next 3 years. Here the safeguarding data is set out, and that's set out clearly in the report in terms of the numbers. I won't go into that in detail now, you'll have seen that in the report. Can we have the next slide, please, Claire? So plans for 21 and 22. So I've been working with officers and with partners to finalise the governance review to make it smarter, to reduce duplication and to make it more efficient. We've been reviewing our subgroups and working with board member organisations in their safeguarding work and to take account of their priorities as well. So I think we have a good plan going forward in terms of how the governance of the Safeguarding Board will be able to deliver in a really smart way that actually should make understanding of our duty to prevent safeguarding incidences more simple and more straightforward. And my mission in life is to work in particular with citizens so that they have a better understanding of safeguarding, because when they do, then prevention is enhanced. And I've been meeting with colleagues in Health Watch, and in fact all the colleagues across the board partners, to discuss how we can work together to commence delivering a community reference subgroup for the board, which will enable more participation and enable us to learn from the experience of those with lived experience of safeguarding intervention. So next slide, please. So we have refreshed how we're working as two safeguarding adult boards together. We've reviewed our structure, and I've talked about transitional safeguarding and homelessness already, and the focus on involving citizens. And in particular, we want to take account of the challenges that citizens and partners have been facing in the pandemic. And we are having a special board meeting, this extraordinary board meeting in November, to consider reports on those issues and to see where we can establish any other priorities for moving forward, because we're not quite out of the pandemic yet. And there's been lots of learning as well. So it's taking account of the learning and then strategizing and prioritizing where we go forward. Thank you. Next slide, please. And that's it. That was quick. Thank you. Any questions?
Okay, thank you very much for that walk through with us there. It's clearly an incredibly important area for us. I'm going to open up the floor for questions on that, and go to Sam Crow first.
Hi, Sean. Really nice to meet you. I just had a couple of questions about the data. It may be in the report, but I couldn't see it. My first question was, obviously there's been a big leap in concerns, which looks like it coincides with the start of the lockdown period. And my second was whether there's any benchmarking around the conversion rate to Section 42 inquiries, because the report does say that there's about a 12% conversion from concerns into Section 42 inquiries. Is that in line with what we would expect for a similar area, and how does that compare to national?
Okay, rightio then. So in terms of the increase during the pandemic, because at the start of the first lockdown, we had lots more people volunteering and coming forward to help and support vulnerable people in communities, most of whom had a small element of safeguarding training. People were raising safeguarding concerns which might not necessarily hit the criteria as defined within the Care Act. So we saw at the first lockdown a big rise in concerns. We then saw a drop and then a rise in concerns again, and that compared nationally. So BCP Council, alongside many other local authorities in the UK, initially there was a voluntary return on data on safeguarding during the pandemic, known as the Insight Report, and BCP Council joined and supported that voluntary return of data. We're into Insight Report 3 at the moment, which is going to be published in October. The data was submitted at the end of August, and I think we'll then have a better picture, because the data in Insight 3 is more qualitative than quantitative, and we'll have a better picture and understanding of the issues around the pandemic and safeguarding. I think it's fair to say that nationally, as safeguarding adult board chairs, we feel that we're really now starting to see the impact of the pandemic in safeguarding terms. It's well known and well recorded in terms of the rise in mental health issues, in terms of accessibility to people who are vulnerable. Many vulnerable people shut the door to people coming in because they were scared and were worried, and we're seeing a rise in incidences of safeguarding in that regard. So I think BCP compares very much with the national rate, the national benchmarks, but we'll be looking at that in some detail in November when we've got the 3 stages of the Insight Report recording and that data to take us forward. And I would be happy, well, indeed, I will include within the annual report for this current year the picture and the trends that will be showing us.
Okay, thank you for that. Got Councillor White next.
Yeah, thank you, Chairman. As lead member for Children's Services, I just wanted to say I'm very encouraged by your comments about working more closely with the Children's Board. I really welcome that. Thank you.
Thank you.
Okay, sorry, I don't know your name, so I have to go straight in. Thanks. Can you just turn your mic on so that I was not going to hear?
Yeah. Brian Ralph, Service Director for Corporate Parenting. Hi. Just echoing Councillor White's comments that it's really good to see the transitional safeguarding is on the board's agenda. We very much see this as a kind of a growth area for consideration. We've certainly seen through the pandemic the rise in mental health issues, certainly affecting younger people and much concerning regarding older adolescents. In BCP as a whole, we have a very strategic issue concerning the rise of criminal exploitation of young people, and that particularly hits the more significantly vulnerable young adults in our community. We've got the effects of trauma in terms of childhood trauma, and that sort of that grey area that you get as a result of childhood trauma and cognitive functioning, and whether or not people are actually able to be fully functioning in the community and vulnerability. So I think it's all really good areas that we need to look into. It has a cross-linkage to stuff we're doing in terms of memorandum of understanding regarding mental health issues and young people. I've just noted my colleagues' other comments about hospital discharges, etc. It's a key feature also in that children's area. So, and a lot of that is to do how about young people are safeguarded, but they live within communities. They live within communities that also have safeguarding issues. And I thought it was really helpful to see the dementia issues coming up. Again, families in small houses and the impacts there. So there's a whole range of issues that we're very happy to kind of work alongside you with. Thank you.
Thank you very much. And I've just actually co-authored an article published in one of the social work journals around leadership and governance in transitional safeguarding. And it's a really important area. In another area of the Southwest, I chair both the Children's and the Adult Safeguarding Board, and we've seen a lot of improved practice through having good governance across the piece. And that's why I was really keen, as soon as I learnt that the new chair of the Children and Families Partnership had been appointed, to meet with him and to discuss how we can have a shared strategic plan around transitional safeguarding. And we've got a year, because we've agreed our plan sort of halfway through the year, we've got a year and a half of delivering some significant improvements in terms of governance and seeking assurance. And I think if we can work together on that, it will make a vast difference to the lives of vulnerable young people, up to their mid-20s in the BCP Council area. Thank you.
Hey, any further comments, questions? No, so if I could just thank Sian for sort of joining us today and extend the welcome to the board. I think we should probably record our thanks to Barry Crook as well as the previous one. As you said, the report predominantly covers his period as the chair of that. So if I move us along now then to agenda item 12, which is the pharmaceutical needs assessment. And I believe we have Jane Horn joining us to introduce this report.
Thanks, Tim. Yes, so Jane Horn, one of the consultants in public health with the Public Health Dorset team. Just wanted to talk.
Very quiet, Jane. Do you want to push your mic up a little bit?
Is that better?
That's a lot better, thanks.
Okay. Apologies. The pharmaceutical needs assessment is a statutory requirement of health and wellbeing boards. They are needs assessments that set out the current services that are provided through community pharmacies and indeed dispensing doctors. It looks at the needs for those services kind of at the time that the pharmaceutical needs assessment is written and looking forward for 3 to 5 years, and then makes recommendations about whether services are currently sufficient, whether there are gaps that might arise in the future, and how we can make improvements to services around access or just service improvements. So the last P&A was published in 2018. There's a requirement to refresh the P&A every 3 years, but because of COVID, obviously that's been put back to October 2022. So the paper before you just sets out really very high level information about the P&A and some recommendations that we need to agree so that we can get the P&A published on time for October 22nd. Previously, the pharmaceutical needs assessments have been done across Bournemouth, Poole and Dorset County. Obviously, the last one was prior to the establishment of the 2 new unitaries. And we wanted, again, to develop the P&A as a single pharmaceutical needs assessment that covers both BCP and Dorset Health and Wellbeing boards. So we need approval from the board to do that. The other thing about how the P&A is developed is that within the P&A, it's helpful to look at a smaller geographical area. So in the previous P&A, we used locality areas that were in use at the time through the CCG in particular, but those have now been really superseded by the primary care networks that are being used by the within the CCG. So what we were proposing was that we use those as a basic framework for the P&A again this time. Again, that will help to bring about closer working in terms of those primary care, or can help to bring about closer working between community pharmacies and GPs within that primary care network area. So I think that would be a real benefit. And the final thing is, given the timing for delivery of the P&A and the fact that there's statutory obligations around how that's delivered, including a 60-day consultation period, we've asked for delegation of authority to the Director of Public Health to agree the final content for publication, so that we're not wedded to making sure we get things to particular meetings. Obviously, we will bring back any updates as required, and but the delegation of authority to the DPH for sign-off. Happy to take any questions.
Okay, thank you, Jane, for that. So I'm going to open up to the floor. We've got Richard Jenkins first.
Jane, thanks very much. I don't know how you take this into account, but the changing landscape is the rise of the online pharmacist. And online pharmacies can deliver direct to patients' homes from distant parts. They can possibly cream off the relatively easy part of repeat prescribing and dispensing, but we still need community pharmacies to deliver acute prescriptions. We need community pharmacies there to look at minor ailments and to give advice. And I suppose I'm concerned that the online pharmacies can destabilise the traditional community pharmacy offer, and I don't know how you take that into account in the P&A.
That's a really valid point, and I think there is certainly a rise in online pharmacies. I think we still see community pharmacies, as you say, as a really important part of local communities. We have high footfall through community pharmacies. They're providing, if you look at the COVID vaccination programme, for example, they're providing, a number of pharmacies are providing quite a lot of the vaccinations. So, they're an excellent partner in a local area. I think one of the things we do need to recognise is that the ways that they work as community pharmacies are often changing as well. So, where you might have lots and lots of small pharmacies, you might have fewer bigger pharmacies in the future for them to be financially viable. But we do need to make sure that we still have community pharmacies, absolutely. So I think that is part of what the P&A is about.
Okay, thanks for that. That gets my question of the day, actually, because that is a big area, that isn't it? How can you do that? Sam Crowe?
Thanks very much, Tim. I think it's a really good question. It hadn't occurred to me, and actually I think it's one that we should take back to NHS England, because I'm just looking at the background papers. The pharmaceutical and local pharmaceutical services regulations were in 2013. I can't imagine that they would be up to date with this issue. So I think it's something that we could ask via the region, because it's a good question.
Okay, any further questions?
So if I just respond to that, we are working closely with NHS England on developing the things that we need from them for the pharmaceutical needs assessment, so we can add that into the discussion.
Okay, thanks for that. So there's no further questions. So I think we'll move straight to recommendations. So we're looking for the support to approve the development of a single P&A that covers both BCP and the Dorset Council's Health and Wellbeing boards. Everyone supportive of that? Yes, nods in the rooms. The use of the primary care networks as the basic framework for the P&A. Yep. And finally, delegation of authority to Director of Public Health to agree the final content for publication of October 22 following statutory consultation. Yeah, so we'll take all of those as approved. So thank you for that update, Jane, and I'll move us on now to item 13, the local outbreak management plan. I mean, hopefully one day we won't need this on the agenda, but I don't think we're going to get that update at this point. So Sam Crowe.
Thank you very much, Chair. If you bear with me, I'm just going to try and share my screen in the right way so that hopefully people viewing online can also pick this up. So I'm hoping that if I go via PowerPoint Live, is that the right way? No? Okay. I've been told that's not the right way. Okay. So if I try a slightly different approach.
We can see it online.
It's about the live stream, I believe. So I'm just going to try a different route. So hopefully you can see that now. Brilliant. Okay, so I'm just going to start with an update on the current position. We're in the unusual situation of the BCP Council area having a lower 7-day infection rate than Dorset Council. Throughout the pandemic, we've normally seen higher rates in the urban area compared with our more rural neighbour. The rate at the moment is about 265 in the BCP Council area. That compares with a rate for South West England of 308 and England slightly higher at 373. In the last week, the over 60s infection rate has started to creep up again. It was below 100 cases per 100,000, but it's now above that level. That's important because that tends to be an indicator of increasing risk of more serious disease and hospital admission. But by far the highest rates at the moment are in school-age children, particularly secondary school-age children, and the public health team is very, very busy supporting schools managing individual cases, but in some instances, larger outbreaks. The contact tracing system in schools has changed, and the mitigations that are available through the Department for Education contingency framework mean that we are having to work more closely with schools on individual risk assessments to make sure that the overall aim of minimising the disruption of education to children is maintained. So previously, where we would have advised schools to perhaps look at bubbles and sending larger groups home, that is not the case anymore. But I think that our head teacher colleagues are relatively confident that the support that they're getting locally is effective in being able to understand who needs to be tested quickly and to get them to isolate as quickly as possible. The current situation with hospital admissions is, I would say, positive. The number of people in the Dorset system is around about 35 at the moment. It's hovered around that level for the past few weeks. And I have to stress that if you look back at the previous year, the level of circulating infection at this time in the autumn was far, far lower than it is currently in the community. So although, we are by no means out of the pandemic and we are seeing lots and lots of infections, the more serious consequence of those infections is being held back by the success of the vaccine programme. So locally, we have done fantastically well in rolling out that COVID vaccine to most of the age groups. We've got over 90% coverage now in the age groups over 25, and increasingly we're looking at reaching those younger age groups. The booster programme is also underway in the Dorset system. We are starting to look at vaccinating in schools, but that is delayed mainly because there is also a priority around delivering an expanded flu programme this year. So we would normally only be offering flu immunisation to Year 7 students, but it's been expanded to Year 7 and 11. Because of that, the pressure on that workforce to get around all of those schools is meaning that we're having to look for additional input to make sure that that programme runs as smoothly as possible. The next slide is, oh, doesn't appear to have moved on. Oh, there we go, just a bit of a lag. So the next slide just shows you the time trend of what's been happening. The BCP council infection rate is picked out in the dark blue, and you can see similarities with our neighbouring councils. We did see a fall after the spike in the summer, but we are starting to see that slowly gradual drift upwards of infection rates, and I'd expect that to continue, definitely continue through October and November. Our modelling that we use to keep a close eye on what's happening over the next 8 to 12 weeks would suggest that if we continue in the same pattern and we continue to make progress with the vaccination programme, I think we'll start to see a reduced number of infections probably through December. And then just a couple of notes on that outlook for the autumn and the winter. The aspect that the model doesn't quite cover at the moment is the waning immunity. So if you remember the time period when people who are most vulnerable and oldest first received their COVID vaccines was almost getting on for 10 months ago. That's why the booster programme is really important. So depending on progress with that programme, as long as we can offer those catch-up third doses to people most at risk, then I'm hoping that we'll continue to see reductions in transmission. The autumn and winter plan that was published about 3 or 4 weeks ago talked about the confidence in the current measures, but it did mention this so-called Plan B. So if things do change, if we do see a rise, particularly in hospital admissions, and we see that increasing return to pressure on the system, then we do have the option of moving to those additional measures. That's likely to mean local introduction of some of the public health measures that we were previously looking at, such as face masks, for example, and it also discusses the use of COVID passports for large events. We had an updated contain strategy published on the 8th of October. That's important for the Health and Wellbeing Board because it sets out the expectations of the local outbreak management plan. Now that we've got that strategy, we are working through the Health Protection Board to update the local outbreak management plan. And I think the most important measures from the strategy I'll just set out on the final slide. The key one for us in our local system is it makes it clear that the Director of Public Health and local councils remain responsible for making sure the local outbreak management plans are effective. We still have the Contain Outbreak Management Fund, and we're looking to work through our key risks, working through the Health and Wellbeing Board. Any future spending from the contingency that we set aside for the winter will be very, very clearly linked to addressing those risks in the plan. So we're going through the process of updating our local plan based on the outbreak interventions that we still have. It was really welcome in the Contain strategy that there is national support to continuous undertaking local contact tracing. So that will continue in the BCP Council area and the Dorset Council area. And there'll be a commitment through the Health Protection Board to continue that funding. There's also extension to the community testing scheme that will carry on until at least December the 31st. That's important because it's now focusing on some of the groups in our population that perhaps can't access testing as readily. And in the meanwhile, lateral flow tests are readily available either through the online portal or community pharmacies. I think the final couple of points I'd just like to make is that there were lots of the original coronavirus measures that were expired. So as we went through step 4 of the roadmap, a lot of the powers that were brought in under that act have now ceased to exist. But councils still have access to emergency measures, if you like, under what's called the number 3 regulations. So if the local situation worsened and we needed to take public health action, either to stop an event taking place because of the increased risk, we still have that ability under the number 3 regulations. And just the final point from me is that our communications focus over the next couple of months is very, very strongly focused towards winter. So we're getting less engagement with COVID-19 communications, unsurprisingly, because the pandemic has been going on for a long time. But over the next couple of months, we're really strongly emphasising the importance of getting the flu vaccination, as well as making sure you're up to date with your COVID-19 vaccinations. So it's a really, really strong joint comms effort called Let's Talk About Winter, which is being delivered not just by the public health team, but by Dorset CCG colleagues. That's going live round about now, so there'll be lots of content coming out by various channels on that, just to make sure that we've got those reminders about self-care and what the steps that people can take as quickly as possible to make sure that they're relieving pressure on health and care services wherever we can. So that's probably it from me. I'm very happy to take questions from anyone.
Thanks, Sam, for that update. I just if there's any questions from the floor on that. I've got Karen Loftus online, so I'll go straight to Karen.
Hello. Hi Sam. It was really just to comment and highlight that there's a great deal of really brilliant work going on in partnership across all the sectors to increase awareness about vaccination, to enable people to make an informed choice. And we've been doing some work with local voluntary sector organisations that work within communities maybe that haven't taken up the vaccine so readily, and we've had great success with helping people to, it's not a badgering, it's very much about an informed choice, and that has been really, really successful. We've also been running some training sessions with our NHS colleagues for our other colleagues around helping people to talk to their clients and service users around it as well. So that has been a real focus. And also just to say around Talk About Winter, the CCG persuaded me to have a photograph of me having my flu jab. And I've been on Facebook and Twitter smiling away with my lovely community pharmacist jabbing me ready for flu. So I don't know why I volunteered for that one, but I think it's just to sort of highlight that positivity that's also going on as well. Thank you.
Okay, thanks for that. I think echo that. It's been a huge concerted effort by so many people, the COVID response and the vaccination rollout as well. Any other comments for Sam or questions? No. Okay, so I think we'll move on there. So I'll go on to item 14 then. This is the development session, just really feedback of understanding on the Health and Wellbeing Board's role in developing the integrated care system. And again, I think Sam's just going to give us a quick overview of that.
Thanks very much, Chair. So this paper really goes back to an earlier paper that we had at the board in June last year, where there was a recommendation that the Health and Wellbeing Board devote some time to thinking about the future of a number of partnerships. One of the partnerships was the growing recognition that the Health and Wellbeing Board could play a really important role in the development of the integrated care partnership. Now, as all systems moved to establishing integrated care systems from April 2022, the integrated care partnership is really seen as the place where councils and NHS colleagues come together to develop a really, really strong integration strategy that will pick up on the things that we feel are most important for our communities to push forward on in terms of improving health and social care integration, but also our wider prevention and community resilience efforts. So the development session was a chance for the board to look at the guidance that's been coming out, but it was also a chance for us to run through 2 or 3 questions reflecting on the development and the role that Health and Wellbeing Boards have played ever since they were first established under the Health and Social Care Act back in 2012, recognition that perhaps it took a bit of time for the boards to find their feet, and we also drew quite heavily on experiences from a King's Fund report that had interviewed many Health and Wellbeing Board members, particularly in recent years, after this concept of integrated care systems had been floated in the policy arena. I think the point from that report that's really important to note is that the impression was that Health and Wellbeing Board's time is really now. So we're now moving into a situation where if we're really going to work as an effective system, having that really strong place-based voice that reflects the needs of our communities through the Health and Wellbeing Board gives the members of the board a really key opportunity to influence the development of that strategy. And then the paper just covers some of the summarised output from the development session, and thank you to Lucy Mears for pulling this together. I've just included some key points there which are covered in the paper. I think it's really encouraging to see that the two chairs of the two health and wellbeing boards that sit in the Dorset system are recognising the importance of working more closely together. But equally, what we heard was that having that reflection of place-based priorities, because of the differences between BCP council residents and Dorset council residents, really, really important to recognise that difference and to continue to be able to articulate the slightly different needs of each area. I think there was a real sense that the exciting bit of the integrated care system proposals is the opportunity it allows to make a real difference on the ground, and equally to feed through some of the on-the-ground experiences at primary care network level and neighbourhood level to influence those plans. But above all, I think the most difficult question that we asked on the day was exactly how is the governance going to work between existing statutory committees, we've got two health and wellbeing boards within our system, and the new governance that's being brought in by the legislation. So that was a difficult question to answer. I think we've recognised that we need to continue to be engaged in that discussion, and there's a piece of work that's now being sponsored by the Systems Partnership Board to look at developing some draft proposals as to how the health and wellbeing boards would fit into that picture underneath the Integrated Care Partnership. So it will emerge, but I was really encouraged by the appetite and the energy and the enthusiasm and the very clear sense that both health and wellbeing boards recognise that they could play a really strong role as the ICP develops. I'm happy to pause there.
Okay, thanks, Sam. Any comments, questions for Sam? No, okay. I mean, I'll just echo the points that Sam's made there. That there's a really good opportunity here to come together really across sort of Dorset and take some of the agendas forward. So I think both sessions were well received. Okay, we'll move on then to final agenda item 15, which is just the forward plan. So it's been circulated with the agenda. I just ask if any members of the board, if they've got any comments or any additional items that they feel needs to be added. Debbie?
I think it's something that we picked up before. At some point, not as a top priority, but at some point it'd be really good to have a look again at the changes taking place with the hospitals on the eastern side of Dorset, of University Hospitals Dorset. We are so fortunate, aren't we? We've got a massive investment programme that will enable us to change things, and that's the beauty of it. It's not all about buildings, but the buildings allow us to do things differently. And the role of the hospital as part of the community and what it's doing, just want to make sure that Health and Wellbeing Board is cited on those changes and that we're responding to the needs of the community in the right way as we develop our plans. So shorthand would be an update on the emergency and planned care hospitals, but the context is not just to tell you about exciting new buildings, but to talk about how we connect well with the community and the services that we provide so that we do the very best for local people. I think it's so exciting, probably much later next year, but we did talk about it with Jan before, and I don't want to lose it.
Okay, everyone content for that to be added on? I should say there's some great visuals now on the UHD website of the future look and some of the 3D sort of almost drone type scroll arounds if you want to go on there. Sam?
Thanks very much, Chair. Just for noting, I think Karen's aware, but we'd like to take a summary of the BCP Council Joint Strategic Needs Assessment through. I think that's for the January board, and that's going to be really important as we start to prepare health and wellbeing boards to influence the integrated care partnership strategy. It's a good chance for us to see exactly what's going on in some of the outcomes that are most affect our communities.
Okay, it's getting lots of nods for that one as well. Any other comments on the forward plan? Councillor Kelly?
Thank you very much, Chairman. I wasn't quite sure whether to mention this, but I think members of the board are aware that we have recently started a new Vibrant Communities Partnership Board. with many partners from, you know, who are here and also more. Lots of people from the voluntary sector, absolutely fantastic. We had a first meeting recently, and we're just in the process of electing a voluntary sector co-chair to go to sit alongside myself. So just to say that, you know, I know that that board will be reporting to the Health and Wellbeing Board here, so perhaps, you know, in time when we've started some items of work, then we can bring them to you, please. Thank you.
Okay, if I perhaps leave that for yourself to come back to Karen when appropriate, we've got something to go on, then we can do that.
Absolutely, thank you.
So if there's no other comments on that, we'll draw that one to a close, and I'll draw the meeting to a close and just thank any members of the public for sort of joining us, and thank all members for your contributions today. Thank you.